In this video, we will be discussing about the orthostatic hypotension, which is a cause of syncope. We are basically studying the syncope, and this is the third video in this series. The first video was about the definition and epidemiology and pathophysiology of syncope. The second video was the first category of syncope, that is vasovagal syncope. This is the second category of syncope, that is orthostatic hypotension. This is a very typical peculiar term which has a proper definition and it is a proper diagnosis. As far as orthostatic hypotension is concerned, it is the most common sign which we see in autonomic dysfunction, right? Or dysautonomia. ये ऑटोनॉमिक डिसफंक्शन का सबसे कॉमन साइन है। अदर चीजें भी मिलती हैं जैसे कि इम्पोर्टेंस, ज्यादा पसीना आना विच इज कॉल्ड सूडोमोटर हाइपर एक्टिविटी, एक्सेसिव स्वेटिंग, बट orthostatic hypotension is most common among all these signs and symptoms of autonomic dysfunction. As far as definition is concerned, it is very important to remember that what is the definition of orthostatic hypotension. There is reduction in systolic BP by at least 20 mm mercury. Right, let me choose the penicillin here. By at least 20 mm mercury of systolic BP. Right, systolic BP. And diastolic BP by 10 mm mercury. And very important to remember is after 3 minutes of standing, or there is a test known as head up tilt test which can be done. uh, it is basically done in hospital settings, but as far as OPD settings are concerned, we can do this uh, measuring of systolic and diastolic BP when the patient comes in OPD and you suspect him or her to be in a state of orthostatic hypertension or a case of autonomic dysfunction. Right. Now, second thing in this is it is a manifestation of sympathetic vasoconstrictor failure. सिंपैथेटिक वेजोकंस्ट्रिक्टर फेलियर क्यों होगा जब ऑटोनॉमिक डिसफंक्शन होगा या ऑटोनॉमिक फेलियर होगा? हमें पता है कि ऑटोनॉमिक नर्वस सिस्टम या बेरोरिसेप्टर रिफ्लेक्स का एक प्रॉपर आर्क होता है। हर रिफ्लेक्स का आर्क होता है, ऐसे ही बेरोरिसेप्टर रिफ्लेक्स का भी आर्क है। इसमें क्या है कि सबसे पहले हमारे बेरोरिसेप्टर्स हैं, फिर न्यूक्लियस ऑफ ट्रैक्टस सोलिटेरियस है, फिर न्यूक्लियस एम्बिगुअस और सीवीएलएम है, फिर हमारे आउटफ्लो ट्रैक्ट आ जाते हैं जिसमें वेगस नर्व है, जिसमें सिंपैथेटिक नर्व फाइबर्स है। जब इन सिंपैथेटिक नर्व फाइबर्स का एक्टिवेशन नहीं होता या इनका डिसफंक्शन हो जाता है तो autonomic dysfunction occurs and orthostatic hypotension is manifested, right? So this is basically autonomic failure. यहाँ पे autonomic failure हो गया है। There is no compensatory increase in heart rate. It is very important. नहीं तो जैसे बीपी कम होता है तो हार्ट रेट बढ़ने लगता है, बट इसमें हार्ट रेट नहीं बढ़ता, रिफ्लेक्स टैकिकार्डिया नहीं होता, बिकॉज ऑटोनॉमिक डिसफंक्शन है। जो कॉम्पेंसेटरी रिस्पॉन्स होना चाहिए था वो नहीं हुआ, तो orthostatic hypotension हो गया। There is some compensatory increase in partial autonomic failure. अगर partial failure है, थोड़ा बहुत अभी बाकी है, काम करता है वो ये सिस्टम, तो there is some compensatory increase in heart rate, right? What are the clinical features of this orthostatic hypotension? Lightheadedness, dizziness, pre-syncope means near faintness, right? In response to sudden posture change. Sometimes non-specific symptoms may be there. Patient may complain of weakness, fatigue, yawning, cognitive slowing, leg buckling, or headache. These kind of symptoms can also be there, which are suggestive of orthostatic hypotension. Symptoms are exacerbated by exertion, prolonged standing, and meals. Right. Supine hypertension. This is very important. It was not there in vasovagal syncope, but in orthostatic hypertension, there is supine hypertension also. क्यों? Because there is autonomic failure. जब आदमी खड़ा होता है तो बीपी कम होना चाहता है, लेकिन हमारी बॉडी बीपी कम होने नहीं देती। जब आदमी लेटता है तो बीपी बढ़ना चाहता है, लेकिन हमारी बॉडी बीपी बढ़ने नहीं देती। This is the normal response. But in orthostatic hypotension or in autonomic failure, there will be decrease in BP when person stands, and there will be increase in BP when the person lies down, which is known as orthostatic hypertension. It is very important. It is seen in autonomic failure. Supine hypertension is also there besides orthostatic hypotension. Causes of orthostatic hypertension. Causes can be primary, causes can be secondary. Primary means when there is no other cause, it is just primary uh, due to some primary kind of disorders. In primary autonomic failure, the central neurodegenerative diseases are responsible. We know these neurodegenerative diseases by the name of synucleinopathies because of accumulation of alpha-synuclein, either in the cytoplasm of neurons or in the cytoplasm of glial cells, either neurons or glial cells. What? There is accumulation of alpha-synuclein. Two categories of synucleinopathies. One is the Lewy body disease. It is a spectrum of diseases in which on one end there is Parkinson disease with dementia, and on the other end there is Lewy body disease or Lewy body dementia. Right. In Parkinson disease there is Parkinsonism also. In Lewy body disease there is dementia, just dementia. Right. So in Lewy body disease we have three things: Parkinson's disease, Lewy body dementia, and pure autonomic failure, PAF, pure autonomic failure, in which there is accumulation of alpha synuclein in the cytoplasm of neurons, right? Multiple system atrophy. It is also a neurodegenerative disease in which there is accumulation of alpha synuclein in the glial cells, in the cytoplasm of glial cells. Other name for multiple system atrophy is Shy-Drager syndrome. So these are the primary causes of orthostatic hypertension. Secondary causes क्या है? What are the secondary causes? Secondary causes are the diseases which affect the peripheral nerves, which are diabetes, amyloidosis, primary amyloidosis, HSAN, uh, hereditary autonomic neuropathy, HSAN. There is something like this. I just forgot the full form. HSAN 3, type 3 category. Yeah, hereditary sensory autonomic neuropathy. So there is sensory as well as autonomic neuropathy. The type 3 is most common, which is famous by the name of familial dysautonomia. Right. Autoimmune autonomic ganglionopathy, paraneoplastic autonomic neuropathy, HIV neuropathy, Sjogren syndrome. These are the causes of secondary autonomic failure. The reason are autonomic peripheral neuropathies. Right. Third category is postprandial hypotension. Fourth category is drug induced. What are the drugs which can cause orthostatic hypotension? They can be alpha blockers, they can be calcium channel blockers, and many others. Treatment of this uh, orthostatic hypertension is, first of all, the first step is you have to remove all the vasoactive medications like nitrates and alpha blockers and calcium channel blockers. Then we have to institute some non-pharmacological interventions like patient's education for staged moves, कि जब बेड से उठना है पहले लेटने से उठने की बैठने की पोजीशन, फिर अपनी टांगे नीचे लटकानी है, फिर आपको धीरे धीरे खड़े होना है, एकदम से ये नहीं कि बेड पे लेटे और एकदम से खड़े हो गए. You have to give some staged moves one after the other in a staged manner. Then second thing you can do is isometric counter pressure measures that we discussed previously in the treatment of vasovagal syncope. What were those? Abdominal muscle tensing, hand grip, leg crossing, leg muscle tensing. The most effective is abdominal muscle tensing, right? Then you can always raise the head end of the bed because in orthostatic hypotension there is associated supine hypertension also. Why? Because of autonomic failure. So to prevent the supine hypertension, we have to raise the head end of the bed so that there is prevention of supine hypertension and nocturnal diuresis also. Dietary fluids and salt to increase the intravascular volume. Right, fluids and salts can also be administered. If these non-pharmacological interventions fail, then we have to institute some pharmacological therapies in which there is fludrocortisone, midodrine, dihydroxyphenoxy, dihydroxyphenylserine. These are the vasoconstrictors, right? If they fail, we have to give some additional pharmacologic therapy, which consists of pyridostigmine, atomoxetine, yohimbine, octreotide, TDAVP, and erythropoietin. Right. Again, treatment first of all remove the vasoactive medications, then employ some non-pharmacological interventions. If they fail, employ some pharmacological therapy. If they fail, employ some additional pharmacological therapy. That is all about the treatment of orthostatic hypertension. I hope you understand the topic. That's all for this video. Thank you.